It's running.
Lovely. So welcome everyone. I'm Dr Linda Colley and I'm Clinical Director for Portsmouth Place for NHS Hampshire and Isle of Wight, and I co-chair this board with Councillor Winnington. Limited public seating has been made available. However, the meeting is also being webcast to allow the public to attend remotely if they so wish. For housekeeping and safety information, if the continuous fire alarm sounds, please evacuate the room and public gallery by the stairwells. Do not attempt to use the lifts. Please assemble in Guildhall Square by Queen Victoria's statue. In order to comply with the Guildhall Trust Fire Marshal regulations, anyone who signed in at the Guildhall reception desk should sign out when leaving the building at the end of today's meeting. May I draw everyone's attention to the fact that this meeting will be live streamed. Everyone speaking via a microphone will be on camera, including those making any deputations. Members of the press and public are also permitted to record the meeting on the understanding that it neither disrupts the meeting nor records those stating explicitly that they do not wish to be recorded. Please can everyone use the microphones, you bend them towards you if you need to, and remember to turn them off when they have finished speaking. We have read the report, so presenters, please only highlight any developments that have occurred since publication. And finally, I'd like to welcome Councillor Chris Dyke, the new group representative for the Portsmouth Independence Party, and to thank the previous group representative, Councillor Raymond Dent, for his contribution to the board. Also, Wendy Rees has joined as the representative of the Hampshire and Isle of Wight Healthcare NHS Foundation Trusts. We'll go round now to do introductions, starting with Helen.
Good morning, everyone. I'm Helen Atkinson and I'm the Director of Public Health for Portsmouth.
Good morning, everybody. My name's Paul Edwards. I'm the Probation Service Health and Justice Partnerships Coordinator, and I'm here on behalf of Board Member Sarah Beattie.
I'm Matthew Willington. I'm the Cabinet Member for Community Wellbeing, Health and Care at Portsmouth City Council and co-chair of this board.
Hello, I'm Lorna Reevely, the Chief Officer of the Hive Portsmouth.
Good morning, everybody. I'm Diane Sherlock, Chief Officer of Age UK Portsmouth.
Good morning, everybody. Roger Batterbury, Chairperson of Healthwatch Portsmouth, Statutory Patient Voice Group.
Hello, good morning, everyone. Ron Shields, Chief Executive, Hampshire and Isle of Wight Healthcare.
Hello, everyone. John Savage, Senior Programme Manager for Health and Care Portsmouth.
Good morning. Vernon Nosal, Interim Deputy Director, standing in for Andy Biddle this morning.
Lisa Granger, I'm the Transition Lead in Adult Social Care and I'm here to present the Autism Strategic Action Plan.
Morning, Frances Soul, Chair in Portsmouth Education Partnership.
Fran White, Associate Director of Policy, Innovation and Partnerships at Hampshire and Isle of Wight ICP.
Councillor Steve Pitt, Leader Portsmouth City Council.
Kelly Nash and Strategy in Portsmouth City Council.
Sarah Daly, Director of Children's Social Care and Education.
Councillor Graham Heaney, Labour Group spokesman for Wellbeing, Health and Care, and also Deputy Leader of the Labour Group.
James Hill, Director of Housing, Neighbourhood and Building Services for Portsmouth City Council.
Phil Foxton, Hampshire and Isle of Wight Fire and Rescue Service.
Anna Martin, Democratic Services.
Thank you very much. We've also had formal apologies from Bernie Allen, Gemma Nichols, Sarah Beattie, Andy Biddle, Natalie Brahma-Pell, Penny Emmerett, Superintendent Paul Markham, Dr Jason Oakley, Wendy Rees, Joanne Shankland and Councillor Hunt. I don't think I've forgotten anyone else. Lovely, thank you. So can I just ask if there's any declaration of interest for this particular meeting? No, thank you. And then if we could go to the minutes of the previous meeting held on the 5th of March for accuracy. Is there any comments? Are we accepting them as a true record? Lovely, thank you. Great, so we move on to our first item on the agenda, which is Combating Drugs Partnership. Welcome, Alan. Good morning. I'm Alan Noble. I'm Public Health Principal based within the Public Health team at Portsmouth City Council. I'm just going to, as you've had the report in advance, I'll just cover some of the very brief points within it and then happy to take questions. So firstly, we've been fortunate to benefit from additional government grant funding over the last few years, which has seen a significant increase in the numbers of
adults receiving drug and alcohol treatment in the city. The figures are within the paper, but you can see that we've had a 34% increase compared to nationally, where there was a 24% increase in numbers in treatment. We're also seeing an improvement in the kind of quality measure, which is people making substantial progress, and that essentially is people being drug or alcohol free, or they're no longer using their problem substance. So, for example, if someone was a heroin user, but they may now be an occasional cannabis user, that would be regarded as substantial progress. There's a number of new developments over the course of the last year, which I've highlighted within the paper. To a large extent, it's recruitment of professional posts, which have been co-located within our recovery hub, or drug specialist nurses up at QA Hospital. Some additional funding for inpatient detoxification, residential rehab, and increasing prescribing of a newer drug called Buvidal, which is like a depot, long-acting form of buprenorphine, which is, although very expensive, is proving to be really effective for people engaging in recovery. I've highlighted the Project W. So when I reported to the board last year, we had identified the specific need of women service users that weren't necessarily being met, and that project is going from strength to strength. We've seen an increase in the number of young people accessing treatment. And if I highlight now some of the challenges, as with everywhere, the funding for this year has reduced slightly, or hasn't taken account of the cost of living. We've got a challenge around our drug-related death rates, and alcohol rates, which are essentially double the national average. There's an element of where deprivation is a link to the number of drug and alcohol-related deaths. And I've highlighted within the paper that although overdose is a factor within the deaths, actually it's long-term health conditions which are the kind of driving factor, and these are probably amongst the most amongst the most high health inequalities in the city. And just to further flag that there's a kind of increasing issue nationally but also locally around ketamine use, particularly amongst young people, although we are seeing it across all age groups, but it is more focused around young people, and it's starting to impact on health issues, particularly around like bladder conditions. And there's some work that we're going to be focusing on in the coming year to try and improve the pathways and the referral processes and training around ketamine use, because it's not necessarily being picked up. The health conditions aren't being picked up amongst young people. I think I'll leave it there, and if there's any questions.
Thank you. Helen, did you want to come in?
Sorry, just to prompt Alan, do you also want to say something about the Navigator project that we saw a presentation of yesterday at the Combating Drugs Board? Because I think there'll be interest in the room.
Yes, thank you, Helen. 4.9 on the paper talks about innovative projects. I think that's one of the things that Portsmouth is well known for within the South East in terms of our drug and alcohol services is our innovation. And one of the projects that was presented at the Combating Drugs Partnership yesterday was around the Business Crime Navigator. This is actually part funded by Southern Co-op and part funded by the Office of the Police and Crime Commissioner. And it essentially is a worker that provides very intensive work with a small number of very prolific shoplifters. There's a very close association between shoplifting and drug dependency. And this worker has seen really significant reductions in people shoplifting, and it's seen very impressive results from some of our most chaotic drug users going into treatment, finding recovery, and then being in a more stable recovery. And we had a speaker yesterday give an example of her journey and how fantastic it had been. So it's an example of the work we're doing, but similarly we have a homeless drug and alcohol team that has a similar approach, working with people who are rough sleepers. So yeah, I'm happy to answer any questions.
Thank you. Helen?
I'd like to thank Alan and the team and the partners he's been working with, because I think we had a very positive, my colleagues to the left were both in attendance at the meeting yesterday, very positive meeting. We had several presentations and really saw such an improvement in terms of, and because it might seem that it's not a good thing to increase the number of people who are accessing services, but that is really important, because actually we are giving the opportunity to change lives. And Alan's always very, he doesn't always say what a fantastic job they're doing, so I want to say it, but particularly the I'm going to call her a service user, the person that's been supported by the navigator. We're going to actually ask if she would be happy to be filmed with the navigator, and we'd like to bring that film here because it really, her story, and I think it's really important for us as we're sitting here in a very formal meeting to get the opportunity to see people's life experience and real stories. Her story is very sad, but with a great outcome at the end, because she has been now free of using drugs and of shoplifting, which obviously paid for her addiction. And it's a really good partnership, can I say, with the police as well, because they've been very much part of this programme, and with the Southern Co-op, who have funded it. But she's now been for a little while, and it has completely changed her life. She basically started using substances at 12, was a child of two parents who used substances, and I think she's about 42 now, and this is the first time since she was 12 that she has actually been substance-free and not unfortunately having to be quite often in touch with the police. So I think it'd be really good to bring it here.
Thank you. I'm particularly interested in the ketamine, because certainly as a GP I've seen quite a few young males particularly come in with bladder incontinence, and when you go to the history there is some ketamine use, and not necessarily a lot of ketamine use either, but just some ketamine use, and I've left them obviously with quite a serious complication now afterwards. I don't know if people understand that that's a complication of ketamine use and whether we need to do a bit more publicity about it, but yeah.
Yeah, no, absolutely. And it's been flagged through urology at QA, and they've seen a 10-fold increase in their referrals for young people where there's a bladder condition. That sounds like a lot, but in terms of numbers, it may be gone from 2 to 20. But that's the tip of the iceberg. So there's a lot we need to do around educating young people around, do they want to get to a point where they're having to have their bladder removed? And, obviously that's extreme, but it's complicated by the fact that a lot of they have a lot of pain. Ketamine seems to be the most effective drug at managing that pain. A lot of the opiates that are prescribed aren't effective at managing that pain. There's a risk of, because they're quite often taking the ketamine for some sort of trauma or what have you, we're replacing potentially ketamine with an opiate addiction. So it's a really complicated issue, and it's something our drug services have to adapt to, because they're not necessarily used to dealing with bladder conditions and that aspect of it. So the partnerships with primary care and the hospital will be really key. Just to say, we're going to be tasking a GP registrar or a public health registrar to do some mapping of best practice, to understand pathways and develop referral processes and a training package that we'll then roll out.
Yeah, and I think that's signposting back to GPs, because they're probably embarrassed to come. A young man incontinent of urine is not necessarily going to come and speak to their doctor about it, but obviously the quicker we find out about these things, the potential for treatments are better. So, Matt.
Thanks, and I'd just like to thank Alan and everyone involved in the Combating Drugs Partnership. As Helen said, we met yesterday for our latest meeting, and I have to say I think it is always a very well attended meeting. We get a lot of buy-in from all participants. We have fantastic presentations, and the one we had yesterday was incredibly powerful. And what I really liked about that was it showed about the way things were done prior to having that key worker in place. Really wasn't making enough of a difference, and we weren't getting the impact. So, and it's really good that we can work with private sector partners like the co-op. And I know there was a discussion yesterday that there's potentially another supermarket chain who are interested in perhaps funding one as well. So that'd be great to have even more. And this is only in Portsmouth, so this is something that a lot of places are looking at in our local area, seeing if we can do that elsewhere, which is really positive. But again, this is on the back as well of our drug and alcohol service in the city being outstanding. It's recognised as such across the region and beyond. And as I say, the fact that we have such well-attended meetings, we have real buy-in by everyone who comes in. And I think as Councillor Hunt, unfortunately, can't be here due to having to have a tooth replaced or tooth fixed this morning. He would have wanted to say, as he did yesterday, about, I think on that particular one with the business crime, I think certainly with his ex-copper hat on, he was really effusive about the difference that can make, and the support that's given by the by that service, but also more generally in terms of how we support people through their addictions within the city, and it is a team. It is massive teamwork. It's real dedication to. It's a real tribute rather to that teamwork that we do in the city. So yeah, really happy to for us to note the report and really thank everyone involved for being involved and doing all the work they do.
Thank you. Yep.
Yeah, I want to ask two questions really, and I'll go with the second question. It was about the detail on 5.7. You talked about the referral of young people to DAS for ketamine use and said 19 received support, but there were 24 referred. I mean, were the others referred to other services, or did for some reason they not engage, or what happened with that?
Yeah, they would have been referred by an agency. They would have chosen not to engage, but the service will have done everything it could do to speak to them, provide them with harm reduction advice. It's for the young people, they have to consent to sign up and share their details with something called the National Drug Treatment Monitoring System. Quite a lot of young people are sceptical of it and will not consent to that and don't want to be labelled as a drug user at 16 or what have you. So that's why sometimes there's a discrepancy. They won't consent to that, but they will receive support to some degree.
My second question was really about 5.4, and it talks about recruitment and retention. I'm curious to know a little bit more about what's going on there, because obviously turnover may be because people feel they're in the wrong job or whatever. What is the reason for the high turnover? You mentioned that people not having experience of working treatment services. Is that about how we advertise the jobs or whatever? And you also mentioned a bit about people with the lived experience. I mean, actually, that's probably quite a good thing to have people with lived experience. Are they the ones not staying or whatever? What's really going on behind that? Because I didn't get a sense of what the real problem is.
Yeah, so I think what's happened is with the additional funding, I mean, essentially our funding has had really big uplift. So we've had to recruit new staff in. I think what we're finding is the new staff that we're recruiting don't necessarily stay so long because that maybe the role is much more demanding than they expected. They've come in, typically we might recruit someone who's a psychology graduate with a couple of year experience or something in the real world. They've come in, they've got a caseload of 50 to manage, and they find people dying on their caseloads and what have you. And it can be quite challenging. So there is a bit of turnover around that. In terms of the lived experience, you're absolutely correct that they do provide really good workers, but they do need more support because there are a whole range of issues around their own history, triggers, their own experiences. Also not for what may have worked for them as a treatment option may not be the right thing for the people that they're working with, so they need not to be evangelical about their approach, if that makes sense. So, but we do, people do relapse, and it is still an issue, and we have to support and manage them through that. So I think for the first time in a long time, we've now fully recruited a lot of the posts, and we're having to finally getting them more stable. And I think that's part of the problem. When you have vacancies, it puts more pressure on the people that are there, and they're more likely to leave. So we need to get to a steady state, and then hopefully things will be, well, things are in a better place. There is if I'm honest, the staff will probably say they need more money, but I would imagine that's the case everywhere.
We say the same at the university, I can tell you. No, I think that's really helpful, actually. And I think probably next year when you report, we may well find that things have hopefully calmed down a bit, and that stability that you talked about will be there. But that's useful to know what's been going on there, so thank you for that.
Thank you. Yeah, Councillor Windham.
Yeah, so just as somebody who's have some experience in industries with lived experience in particular, I think Alan's completely right, and it's not just drug and alcohol services, but it is others in similar ones where you're dealing with people with lots of trauma. It's just attritional, and as has also been mentioned, especially if you work for the VCSE, the voluntary sector, often the pay isn't great. So, which is just a reality of it, and so therefore there's potential. You're getting paid not very much to deal with lots of very difficult circumstances. So, I think it's that's that general thing. The other thing is also, and just to back up Alan on the lived experience stuff, as it happens, and we'll come into this later when Fran will be presenting, but we've got a workforce assembly for the Integrated Care Partnership next week. And one of the things we've been talking about at the Joint Committee is about when people have lived experience, you have to recognise that there is additional support potentially needed for people, and it's about getting the sector as a whole, so the statutory sector especially, because they generally haven't had people with lived experience so much within that. Now that's changing, but also the VCSE as well, in terms of making sure you've got that extra support there, and not just thinking we're going to employ a load of people with experience and then you just leave them to get on with it, and then that's when people go off sick, relapse, whatever, because it just becomes an unsupportive environment. So I think it's a really good question, Graham, and I think it's something that that as a from a local authority point of view and statutory organisation point of view, it's something that we're always aware. We've always been aware of anyway, because it happens with a lot of our in-house services that we deal with. But it's also increasingly the fact that in terms of the thing. But we as we have the voluntary community social enterprise sector more involved in all the work we do, it's about recognising that we have to support across organisations to make sure that we do that. So I think it's a good question, and it's something that we are looking at from a system point of view next week, because it's very much about, one of the big themes is about recruitment and retention in the health and social care sector across the board. So just thought that might be helpful.
Thank you very much. So we'll move on now, thank you Alan, to improving outcomes for adults with multiple disadvantage. I believe Helen wants to say a word before James.
Sorry, no, just to say James is going to, so we're just bringing Joe and Alan to support.
Perfect. Over to James.
Okay, thank you, Chair. So yes, just presenting the report on behalf of Helen as well. And as Helen said, we're joined by Alan, who's been introduced earlier, and Joe Bennett, Assistant Director of Housing Need and Supply, who will talk to you about the next steps contained in the report. So I'll just briefly introduce it to you. So this report actually brings together details that were discussed at a Health and Wellbeing Board development session on the 8th of May. And I'd just like to thank Kelly Nash, Matt Gummerson, Dave Adams and Hayden Gins, who pulled together lots of local and national research which helped that debate and discussion, and also to those present here that participated in that development session. It was a really good session. We had a discussion about all of the learning to date, the learning that came from the rough sleeping review, and that debate and discussion framed the report and the next steps, which we'll come on to. So this report touches on the health and wellbeing strategic aim, which is about the ambition to improve service delivery for adults in the city. And in section 5, you'll see that we pulled together for the development session all of that learning, and the Health and Wellbeing Board development session very much recognised the good level of knowledge that exists about individuals or cohorts with multiple disadvantages or complex needs. There are various labels used, and particularly the learning present in the city from thematic reviews, and those are referenced throughout section 5. The board will remember that in November 2023, we took a decision to focus on rough sleeping day services, and that work progressed and is already reported here. We've summarised the learning from that review in section 7 for all to see. And I'd just like to update you all in section 7.2 and 7.3 of the positive impact that moving the location of the rough sleeping day services has had, and particularly in the ability then in that move to take forward some of the learning from the review. So we've immediately seen a positive difference made to those accessing those day services, particularly in the way in which the building supports much better service provision for them, and also provides the opportunity to continue to take forward the learning from the rough sleeping review, particularly in how other services can be present in that setting, so that when those that are rough sleeping request need or support, we're able to try and provide that in the immediacy rather than delay that provision. So a really good opportunity to continue to take forward the learning. In terms of the discussion about the next steps, the only thing I would highlight before handing over to Joe and Alan is that although the development session recognised that we would wish to continue to use the systems methodology, which very much looks at services from the perspective of the customer, the user, the client, however we describe the individual, there was recognition that the wealth of learning that we have now over time, and indeed the repetition with which each review seems to land on a model with similarity, which is shown in 8.6. If we continue this work, which we will do, there is an opportunity to do so with in a rapid way. We don't need to relearn things that we've already learned. We can take some pragmatic decisions as to how we take this forward. So the next steps then outline the proposal to continue the work in focusing on that strategic aim. I'll hand over to Alan and Joe to introduce that.
Thank you, James. So in essence, the paper states that what we're looking to develop is a dedicated multidisciplinary service to work with people with complex needs. And the paper lays out in 8.6 the areas that we'd look to do, but essentially creating a team around the worker where we would have dedicated lead professionals doing a lot of the work with the person in a multidisciplinary approach, but having access to professional workers in a number of fields, whether it's probation, mental health, physical health, to pull on for advice and support as when needed, but also to enable them to access the individual they're working with to that support. And what we're looking to do is to potentially build on something we've already got, which is our homeless drug and alcohol team, which has essentially been developed to support people with their complex needs. So part of that team, we have psychology staff, we have a social worker within the team. We work really, really closely with the housing service. So there's a real opportunity to build on it with the support of a wider team of professionals. So the process that we would go through, at least in this initial stage, would be to pull together that team, that intervention team with the professionals, multi-agency, to follow the process that's laid out in the paper in terms of studying the demand, looking at the purpose of the service, the workflow, but then quite quickly moving to a point of redesign, which is to essentially look at how we can make it work practically in the city, how we can get the buy-in from the specialist agencies to support the homeless drug and alcohol team, what else we might need to support those that are homeless or have got multiple needs, that maybe substance use isn't one of those needs. And then at each stage of the process, the team would present to the key stakeholders and decision makers to get their permission to move on to the next stage of the process. So essentially, it would be seeking your buy-in to continue with the process. And if stakeholders aren't happy with that, then something different is done, or it follows a different path. So essentially what we're looking for from those key stakeholders is a dedicated practitioner, frontline practitioner, to work as part of that team. The initial phase would be around 8 weeks, and then moving on as the work and the findings and the team demands.
Thank you. Any comments or questions? Councillor Heaney?
Yeah, I really found this paper really interesting, actually, and I'm quite a fan of the systems approach. There have been quite a number of attempts by governments at different times to tackle the issue of family, social, economic problems. You know, back to the Labour government in 1997, social exclusion. Then we had the Troubled Families Project in the coalition government, and all these. So I presume we have been able to learn some lessons from those particular things. But I'm wondering how this will proceed, because I can see what you're trying to do. You want buy-in from different organisations, different parts of the local authority as well. But there are two problems. One is, are we sure that everyone is convinced that they want to change? I mean, it seems suggestive was, so is that the case? Secondly, funding. Government will announce funding streams, and that can sometimes skew how you do your work. So are we able to feed back to government departments that actually what we need to do is to fund the holistic approach rather than fund the bits and pieces you might want to focus on? That's a bit of a rambling question, but I hope I've identified some issues there which I think are interesting. Buy-in of everyone, learning from history of previous schemes, and funding streams for the future. Are they going to be a barrier potentially to doing this?
James, yeah.
I'll sort of start. Helen, the others may wish to chip in. I think in terms of the buy-in, the reason the paper is an information only as opposed to a decision paper is because at the Health and Wellbeing Board development session, we certainly saw their agencies agreeing to commit to the work. We need to follow up some of those discussions, and there are bits of the system which we're yet to see the commitment coming through, but certainly there's sufficient buy-in and support for us to feel very confident that we can take the work forward. The funding issue, yes, with these reviews, and we saw this with the rough sleeping review, that occurred at a point where there was no certainty of government funding going forward. But I think we were mindful of that, and that will be the same in regard to this particular topic area. It does provide the opportunity to strengthen the evidence base for the local authority and its partners to make the case to government that funding should continue, because you are absolutely seeing the impact of the current funding, its positive impact, and the need for it to continue to yet. So in that sense, it reinforces the evidence base, and we certainly present that through cabinet members and through other channels.
I think so. That's definitely the approach to take, but I think it's also important to recognise that we have current funding. I'm not saying that we would never want to have additional funding nationally from government, but I think important, this is about a different way of working, isn't it? It's about bringing our resource that we already receive through grants, through different sources, but also bringing people together. And one of the other things that you said, what I actually think is really important there, Councillor Heaney, is what we've seen from the really fantastic work that James's Systems Thinking team have led is how appalling experience point is we all come into work, all of our teams do, to do the right thing. And the way we are delivering those services at the moment, not for want of really wanting to make a difference to those vulnerable people's lives, it's not working because people, well, maybe not working is the wrong thing, it is working, but what we're seeing, and there was an example from the systems thinking work of somebody that was hitting our professionals, that's in the NHS, mental health, our substance misuse services, our home services, in a period of time, 130 times. So the way that we are delivering services currently is not getting the best experience for those vulnerable people. I hope nobody doesn't agree with that or feels offended by that. But the reality is we've got to change how we're working. And that the team, Kelly, Hayden, Matt and David, have really looked at what the evidence says. So this is about trying to adapt. So even if somebody doesn't want to necessarily change the outcome for their life, what we're doing is giving them the best opportunity to do so. That's what we're trying to achieve. And we have seen, and it is heartbreaking, when our staff are seeing people just go round the system and not actually achieve an improved health or opportunities. So I think that's what this is about, actually. So that it's about doing it differently.
Councillor Pitt.
Thanks, Linda. I'm actually a fan of Team Around the Worker, and this is, I believe from memory, a direction of travel that we'd actually started to move towards before the pandemic, and then we got overwhelmed by the pandemic and everyone in and the outcomes of that, and it's taken time to get the system rebooted. But to me it's completely logical. If you have an individual in an ideal world and you could sit them on a chair in the middle of the room and they felt comfortable with that, and surround them with all the people who might be able to feed into a better outcome for them, you would find out a better outcome, because you'd have one single narrative and everybody with different expertise will pick up on different bits of that narrative. If you compare that to saying to somebody, here's a long corridor with lots of doors on it that you need to go and knock, please go and knock on every single door and everybody will pick up on a bit of your story, and at some point they may or may not communicate to each other. Why on earth would you want to do that? Now, the system pushes us in that direction often, but I think this is an opportunity to buck against that and say, actually, and I've seen this work in children's social care effectively as well, it is about having a multidisciplinary team and having the person who has the best buy-in with that individual case as the lead, but fully supported by a network of other people to make sure the outcomes are right. So I think it's absolutely the right thing to do. And I just want to take the opportunity for any colleagues in the room who haven't visited the new day service but want to and going to see what it's like down there, please do, because it's transformational compared to the previous experience, which is not great to say the least. And there is also down there a private meeting room and an opportunity for people to actually go on site and specifically interact with the client. And given the fact that we are proposing to move towards this model, that's an even better way of making sure that that sharing and experience is there with the right people to support. So I advocate for this quite strongly. I think it's something I've seen work in practice before, and it will need time to develop and grow, and the systems thinking thing in this particular instance will work well, I think, but the alternative to me is completely mad.
Thank you. No, I agree, and you hear it quite often from patients, don't you? I only want to tell my story once. I don't want to have to keep telling it, because it's quite traumatic often what they've been through and having to currently tell it. So having somebody they can really trust and share with that can then bring in resources got to be the better way forward. Roger.
Absolutely agree, Linda. Scratch your microphone. Yes, I think patients always say they only want to tell their story once. I'm just wondering who the key partners are, who's kind of said yes, and perhaps without going into who said no, just who those key partners are.
I won't tell you if they've said yes or no yet, because I think it's a work in progress. But we are looking at certainly the drug and alcohol services, housing, probation, mental health, primary care. Potentially we're looking at some peer and lived experience support within it. Have I missed anyone else?
You've already got the social workers and the psychologists in the team.
Yes. Oh yes, the acute hospital, thank you.
Not feeding you
No, but that's...
We'll take it.
You're answering your own question. Thank you.
I think that's important, though, isn't it? Because everyone has got a stake with these people. We're all touching these people every day, and so everyone's got a stake in helping them. So, it should be good buy-in.
The police were the other one I forgot.
Well done.
Lovely. Thank you very much. So, we'll move on to Community Safety Plan, and we welcome Caroline.
Good morning, everybody. So I'm bringing you the Community Safety Plan 2025-2028 for your approval. This plan is a statutory requirement. It sits alongside our requirement to develop and deliver a needs assessment, and now we need a plan to address the key issues facing our city. It's the first comprehensive plan refresh presented to this board since the 2021-22 plan as we were coming out of the pandemic. And that's because we've brought back consistently that plan in its development, but we've agreed to carry forward its priorities in 23 and in 24. The plan this time has benefited from the presence of a community safety subgroup that supports your work, which has enabled us to work collectively together to consider the priorities for action that were brought to you previously this year, and then subsequently how these will be delivered. As previously, this plan in the main is about bringing activity together and demonstrating connectivity between activity, such as the Combating Drugs Partnership that you've already heard from today, rather than reinventing or duplicating any effort. But it does give us the opportunity to consider gaps in our current provision and to work together to think about how to address them. So in terms of the priorities, you have had the paper, so I'm not going to go through them and how we're going to deliver them, but I can take questions on that. What I'd prefer to do is just give you a couple of updates in terms of each of those about where we've got to already, because as I said, this is interconnected work, it's work already in train. So we've got several strategic partnerships that are already existing that provide good links into our work around priority 1, which is to continue to address the most serious forms of violence in our city. The first meeting of the Portsmouth Board has happened. That happened earlier on this month. This is a development from the previous domestic abuse strategy group, and we've had revised membership and terms of reference to reflect that. We've also developed some theory of change models around the different pillars in that piece of work so that we can now look to have comprehensive delivery plans across all 4 areas. Aligned to this work, we've worked in partnership with Hampshire Constabulary to support the refresh of the Portsmouth and Hampshire East Area Tactical Strategy to tackle violence against women and girls. This has been a really good piece of work, and I'm sorry that Paul wasn't here today to be able to share it, because I think it brings our agencies closer than ever before in terms of addressing the violence against women and girls agenda. And that will also be part within the governance of the Violence Against Women and Girls Board. If we move on to priority 2, I probably don't need to say anything other than just to reflect again on the fantastic work that Alan and team are doing to deliver against this priority. And that continues to underpin our response in this area. And just to reflect that these priorities are interconnected. So if you look at priority 2, you'll see that work around delivering a women's only space, specifically around substance misuse, and that of course then feeds into our ability to protect women and girls from violence in priority 1. For priority 3, it continues to be massively important to us that we identify and support our children and young people at the earliest possible point to prevent exploitation and risk. And this is an area where work, again, that we're doing to deliver against our serious violence comes into play. So there'll be development of the Young Futures panel that we're expecting to be set up in October of this year, supporting and looking to divert children from escalation between the ages of 10 and 17, so reaching those children earlier. But it also is very complementary and runs alongside the work that we have through our VCS providers and play and youth services in the city to present opportunities to our young people through diversionary activities, and we're also looking at a piece of work to further connect the dots there, because actually there's an awful lot of work going on in our city, but not everybody always knows about it. So we end up with young people who aren't, or services not sure how best to support young people to connect into that. So we're looking at that within this piece of work. For our priority 4, this was a new but old priority, one we looked at before but we brought back, which is about making sure that we really connect the dots where we have people with particularly complex needs. There's work underway. We're looking at a scoping exercise for our place-based approach in the city centre. So that's thinking about how we can take the learning from activities like the systems review into that physical place, because we know in the city centre particularly we've had a range of different issues, sometimes with cohorts that we're working with, so similar to some of the work we've already heard about and that learning, but how can we address that in a place-based context? We've also got things like the Keeping Town Centres Safe this summer initiative that was announced by the Home Office that is supporting us to have additional policing in the city centre and other areas in order to target a multitude of crime, including ASB and acquisitive crime, particularly in the city centre. And also, we've been able to look at how we draw together and think about our gaps to work to deliver bids to places like the OPCC's funding network for things like a contextual worker. This will be somebody who bridges that gap between children's and adult services, therefore looking at those young people with complex needs who might just fall between those two intersect. So again, trying to create that seamless journey. So I think it's been a really positive exercise so far, drawing together that plan. The plan will now continue to be monitored through the work of the subgroup, and we'll be bringing back regular reports to you as you require them. And I think in summary, I think it's a good demonstration of the way that we all come together to want to support one another, and recognising that all of our outcomes depend upon one another's success. And I suppose it is the Portsmouth way, isn't it? In a sense that we want to work in partnership to address some of the very most complex issues in our society. So I submit it to you for approval.
Thank you. Any comments or questions? I mean, it was a very thorough paper with a very clearly laid out plan, which I think we can all get behind. We've been asked to specifically approve the plan. Are we happy to do that? Yeah, lovely. And we need to agree that responsible authorities take the plan forward for endorsement by the respective senior management teams to support a unified and collaborative leadership approach, so we can all really buy into this plan. Yeah. And note, following the approval of the plan, the community safety subgroup, you've mentioned that already, will oversee and bring reports back. Yeah, that's great. Thank you so much, Caroline. Autism strategy and action plan is next. Thank you, Vernon and
Thank you. A very brief introduction. The paper's obviously been read and circulated. I'd just like to say I've been here for 4.5 months, and working with this group, I think it's an exemplar of co-production in action. And I'd like to congratulate everybody who's contributed to the report. It's one of those aspects of work that I think at senior level you can get tied into strategy, finance, all of the things that are deemed important. And I have to say that the time I've spent with this partnership group, be it very short, I have loved every minute of it. It reminded me of why I wanted to be a social worker. And I can't congratulate the group enough. So enough of my waffle. I will hand off to Lisa.
Thanks. And just to give a bit of background and context, the last autism strategy that covered adults ran out in 22. So since then, this has been in development and work. There's also been work around supporting autistic adults and neurodivergent adults. So it's not that it's been forgotten in that time, but we wanted to make sure it was co-produced and it was really reflective of what the autistic community wanted. So we wanted to make sure we took the time to do that. It builds on research that was completed in the city and published in 22. And that was, again, co-produced with the autistic population. So we we drew on the recommendations for that, worked with our autistic community and the Autistic Community Forum to draft it. Once it was drafted, it was then shared again with the community forum in a number of formats. So we made sure there was an easy read summary. Our transformation lead also recorded a summary so that people that maybe were finding it difficult to engage with the written word could hear it and have their comments. So yeah, as I said, the priorities follow on from the research, and the community agreed that those are still accurate and correct. So it's about improving understanding of autistic people, neurodivergent people in their lives. We wanted to move away from acceptance and into understanding, so we can really embed kind of an inclusive approach and make sure that people can access and feel welcomed rather than just accepted. And then that is embedded through the other 4 priorities. So improving health and well-being. We know that autistic people have poorer health outcomes, that there are barriers to accessing health services, there's comorbidities and often diagnostic overshadowing, so maybe things attributed to autism that aren't. So looking at addressing some of that. It's ambitious, we recognise that, so it's going to take some time and build on it. Developing better and care and support, and again that comes back to that understanding. If we understand the needs, we can assess the needs better, we can make sure that there are appropriate support services to meet those needs. Appropriate housing, because we know environment is so important and the impact on autistic people and how they process and understand and their energy levels. So we're working with housing colleagues to make sure we've got the right housing available, and then accessing education and securing employment. In terms of the actual actions to meet these priorities, some of the key points around developing workforce and people's skills, confidence in interacting and working with autistic people, about adapting existing resources, so as I said, that kind of inclusivity, making sure things are accessible, reasonable adjustments are in place, but also developing those autistic-specific services where we know actually that's where people feel safe initially to then broaden out into the wider community. And we also recognise there's further work to be done with specific groups within the autistic community, so ethnic minorities, those that identify as LGBTQ+, that may have specific needs within the wider community. So, as I said, there's ongoing work already. So Room 1 is an autistic safe space with some peer support, and we're getting some really good feedback from that support, and some of that's included in the appendices to the strategy. Staff in health and social care are already undertaking training such as the Oliver McGowan, and we're looking at expanding that. And we've also, some of the autistic peers within Portsmouth have done a video so we can understand actually the unique experiences in Portsmouth. And we've got an employment support service that's kind of developing and evolving called Workwise to support that stream. So in terms of the ask of today, it's to approve, accept, support, promote this strategy, and also to think within your organisations, your networks, what you can do to support that inclusion, that understanding, not only of the autistic people maybe coming in, customers, service users, but also you've likely got autistic and neurodivergent employees, so how your employment space can be supportive and inclusive. Happy to take any questions with Vern.
Thank you very much. Roger?
Thank you. A really interesting read, and great that it's been a co-production. 2 questions. I hear that the referral from primary care is to non-NHS providers to get a diagnosis or treatment plan. Just wondering what the expected wait would be. Just thinking of, the real world where people would be saying, I've been referred, how long's the wait? And where will people find details about involvement in this process if they wanted to participate?
I'm not sure I'm necessarily the right person to be answering the question about the diagnostic element. I know we do have, the ICB have commission services for that, and certainly part of that is around working to address those and look at those wait lists, but I'm afraid I personally don't have those numbers to answer. But
I
I can probably come in a little bit. So certainly as a GP, we're seeing talking about improved understanding. I think there is improved understanding in the population because we're getting a lot of adults presenting saying they believe they're on the spectrum or ADHD. You know, neurodiverse in general is definitely highlighted. There is an NHS pathway. PHL run the local NHS pathway. It is a long wait. I can't be precise, but we're talking years, not months. So people are given the right to choose through the right to choose pathways, and we give them the details and they go and choose a provider. Now for the autistic side, part of our job as the GP is kind of talking about what are you hoping to achieve with the diagnosis, because actually there is no treatment for this. This is how you are. What is it going to achieve you, and directing them to places like Room 1 where they can get the support and actually encourage them to talk to their employers, because actually the label itself isn't going to change for them. The ADHD is slightly different because potentially there are medication options, and so I think it's part of us all understanding what is out there, what can you do without having that magic label that may well take you a few years and isn't actually going to change your outcome. And I think as a city, that's what we're moving to with children, because it's not about the label, it's about what help do you need, what support do you need, and let's get it for you now, not wait 2 years for a label and then try and get something. So, yeah, we are seeing a lot more, and it's put an enormous strain on the local services. And there are lots of providers out there that will do, but we have to be careful because some of them, if they are for the ADHD side of things, for example, unless they do proper shared care where they're properly monitoring and following up, then the GPs won't take on that shared care with them. So it's a minefield at the moment. But certainly having Room 1 somewhere as a GP I can say right now you can go and get some help and support is really valuable.
I was just going to pick up as well on kind of the work that is being done in children's in terms of that better understanding, better expressing their needs, and hopefully that will filter on, and we're very aware of trying to bring those strategies alongside. What we are recognising is that adults now have had a very different experience than the children that are coming through now, so it's making sure we address those needs as well as bridging that.
And I think if I can pick up on your comms point, because of the co-production element, one of the things that's been interesting that the group has identified is the need to reach out to a more diverse group, because I was reflecting on my experience of working with someone from South India who mother had dementia, just as an example. But there's no word in the language for dementia, so how do you contact people to get them to understand that? And we've wondered if that is the same across different groups in Portsmouth. So the group identifies itself as being predominantly white male. And they were looking at how do we reach out to faith groups, community groups, in order to get the message across and then to be able to work to support people. So I hope that kind of covers it. But it's, as you'd see, it's a 2 to 3 year plan, and it is very much work in progress. So I hope that helps.
I had 3 questions. First one's quite simple. I don't really think I know what hospital passports are, and I'd be grateful if someone could just briefly outline what they are and how they work. Because you're thinking about possibly it might be useful for people, but it's not been decided yet.
Yeah, a hospital pathway, it's about me, and so it helps express what someone's needs are, what someone's preferences are, but also what their presentation is. So it's a kind of page that someone could give to a hospital staff member, and it will say, if I'm presenting like this, it means this. So if someone's in distress or not able to verbalise, it's a way to explain their needs, preferences and presentation to the staff working with them to better inform how to work with them.
I know some people with rare blood groups have a card which has the blood group, so it's that sort of thing, but explaining more detail. Okay, that's good. Second question was on the same page, actually, page 25. It talks about annual health checks, and it says, implementing annual health checks, and it says, responsible to be confirmed. I would assume it would be GP practices doing this, and are they happy to do this, and have we a mechanism for making that happen?
And I think this is following on, there was a trial in some other areas around extending the learning disability annual health checks to autistic people. I think we're still waiting to hear the outcome of what that trial was and whether that will be extended. But if it's not extended, then certainly that work with can we look at primary care to offer something similar if it's not mandated.
So are you saying it would be voluntary for practices to there wouldn't be a requirement? I mean, this is just like, we'd like you to do this, but if you don't do it, you don't do it.
It would most likely have to be a funded service. Somebody would have to pay for it to be done, yeah. And all you'd need a register of the people, and then you could do an annual recall like we do with the learning disabilities. But it's very clear, obviously, autistic people are not necessarily learning disability. There'll be some overlap, but a lot of them won't fall in that category, so won't currently be getting the health check. And the health check, it's quite good because you make sure, are they getting dental care? You know, you do a quick run through of all the systems. Is there any problems anywhere? Blood pressure, some bloods. And just check they've had everything they need. And it's usually done by kind of a healthcare support worker in the first instance, who can just ask the basic questions, and then any problems identified will then be passed up to the GP. So there is a defined pathway that we could use, but it would need to be funded, I would suspect.
My last question is on the section 4 about housing options. It's a more general question, really, about a lot of this appears to be about what we do internally as a local authority with assessment, etc. But the issue is housing providers. What liaison is happening with housing providers to make them aware of the people who might be referred to them as a housing association, or maybe housing people who have autism, and also the private sector. To what extent do we liaise with them about that and help them to be aware of and help people in situations where their housing may be causing them a problem, and they could possibly have something reasonably simple to sort it.
And I think, as I said, it's ambitious and it's a big question. So it's probably, some of this is about getting it right internally first, so we're really clear, and then we can go out to those wider providers once we know clearly what the ask is. So it's working with potentially housing, and you're right, it's probably something that could be expanded in here, but knowing what we're going out to people to ask for and being really clear in that as well. So I will definitely pick that up and take it back as something we can look at adding in and exploring further.
Thank you. Diane?
Just a little note. I married into a family of neurodiversity and autism, and discovered that in my second son in the early 90s, and it's just such a joy to read this report and to see what's happening, because the only way I could learn was to take enormous tomes out of the university library where I was working at the time and educate myself. And I remember my eldest son, age 5, saying, "Mummy, why do you say everything 3 times?" And I remember replying, first time he hears there's buzz in the room. Second time, he might register I'm actually talking to him, and the third time he will respond to what I'm saying. And that just seems like a million years ago now when I read this, and it's a joy, and I'm so thrilled. And I've learnt so much in my tough experience, but to have had this sort of support. And my son has always said, I'm not a label. And he was adamant from that very early on. Because it came out of an interesting, I shall use that term in every sense, situation in his first year at school. So, well, thank you very much. It's amazing work. Brilliant.
Thank you. So we're all asked to accept this and to hopefully take it back to our organisations and help support it. Thank you very much. Yes, sorry, Ivan.
Madam Chair, Lisa's a little reluctant, a little modest, but I just wanted to point out that the LGA have taken Room 1 as an exemplar in terms of the work that's done, and there's a note with the LGA that says that people should look at Room 1 as an example of how to work to develop autism services. So, as you can see, that so I was keen to ask Lisa to do it herself, as it's not just her work, it's team, but as I jumped in anyway. So,
well, a huge thank you from the Health and Wellbeing Board team to that team. It's great that the city is recognised for the great work it's doing. Thank you very much. So we're going to invite Dominique to join us for Air Quality Update.
Thank you. I'm Dominique Latouze. I'm Assistant Director of Public Health, and come to give you an update on air quality. We came to the board in March to give our annual update on the air quality and active travel work stream that delivers that element of the strategy. And there were some questions asked at that session and a couple of other developments that I just wanted to update you on. They're all in the paper, so I'll just very briefly go through the key points. So the questions from the last Health and Wellbeing Board, the first one was what's happening with the clean air zone. We have a clean air zone in the city that was reviewed in November last year. Transport have come back to us with, pointing out that there'd be a report presented to Cabinet in July, which is an update on the Clean Air Zone that goes over the targeted feasibility study, which Transport have been working very hard on with DEFRA, and that will outline next steps. So I'm not able to give any further update at this stage, but that will all obviously be in the public domain, and that will be part of that presentation to Cabinet. The second question was, has the £2 bus fare cap been observed to have increased bus usage and therefore contributed to improving air quality? Again, Transport have come back to us on that one and said that actually a comparison with local transport authorities by the Department for Transport for the year up to March 23 showed Portsmouth as the city with the best recovery of bus passenger numbers to pre-COVID levels, which is excellent, and passenger numbers were really strong up to March 24. We've also had, as you know, a really strong investment programme in buses over the last few years, including 62 electric buses, which are coming online slowly. So Transport felt that given all of that context, in terms of the wider investment, the increase in bus numbers, it's not really possible to determine which of those factors would be has contributed to the increased passenger numbers or to air quality, but it is having a positive impact across the board, which is excellent. The annual air quality status report has just been issued. We regulatory services, report every year to DEFRA for air quality across the city. That's found that on many of the city's busier main road links, there's actually been a reduction in nitrogen dioxide emissions, which makes progress towards the national air quality objective, which is to protect human health and the environment. And actually, significant reductions have been recorded at some of those air quality management areas that we know are an issue. But in quieter street locations, away from the main roads, we're not seeing that same level of reduction. So while we're having some success at reducing travel-based emissions, those impacts are less pronounced in other areas. So it's obviously a work in progress, but we are making progress. Clean Air Day was last week on the 19th of June. We had a cross-city promotion campaign to encourage people to try sort of cleaner, greener ways to travel and other things. Bus travel was free on that day and promoted through social media, advertising, and the new Planet Portsmouth brand, which links some of our climate work as well, and air quality. And this is part of the Council's obviously ongoing work to reduce emissions, protect public health, and support people to make sustainable travel choices. The final thing on the update was the air quality strategy, which is having a refresh. Consultation on that strategy will take place over the summer, with a finalised strategy due later this year. The mission for the revised strategy is that everyone in Portsmouth should be able to breathe air that doesn't damage their health, with 3 elements to that. We'll reduce sources of pollution to prevent air pollution, will limit exposure to pollution or mitigate, and finally protect the most vulnerable that we know experience the worst ill effects of air pollution. And there are 8 strategic actions that hang on to that. First is to continue all the work that we're already doing that I've just mentioned on infrastructure, technology, which will contribute to cleaner air. Secondly, to raise awareness and provide solutions for poor indoor air quality in the home, and we've seen a lot more focus on that. Chris Whitty has just released another report with the Royal College of Physicians this week, highlighting again the impact of poor indoor air quality. Thirdly, to raise awareness of domestic wood burning and the damaging effects of that. Fourth, to use natural infrastructure, greening, trees, green screens, hedges to limit or improve air quality. Fifth, to promote guidance on building maintenance and ventilation to promote indoor air quality that housing are leading a lot of in the city. Supporting energy efficiency and cleaner heating solutions that, again, housing are leading the way on in the city. Raising awareness about air pollution to reduce personal exposure, what we can all do for ourselves and our families to limit exposure. And finally, to promote training for healthcare professionals that we've had some success with the Clean Air Champions programme that we've been running for the last year. So when that's finalised, we'll bring it back for information here. But happy to take any questions. Thank you.
Thank you. Any comments or questions? Councillor Heaney?
Just a brief comment. I mean, the Cabinet actually did have a report about this back in June, a couple of weeks ago, and I thought it was quite interesting. I think it seems to me the problem we've got is that within the CAS, if we were to, for example, increase the type of vehicles that we penalise, the likelihood is they'd just move out of the CAS and come into the city by a different route. It would just move the pollution somewhere else. I suppose one of the things that seems to me that might be worthwhile pursuing is whether we can accelerate work to get commuters, particularly coming into the city, to park, to use the park and ride. Obviously, there's a longer-term scheme there, I know, in terms of the capital required to increase that, but trying to encourage people not to bring their cars right in and providing alternative means through buses, for example, to get people into the city so they don't have to park, would possibly be one way of doing it. But it's the report also says that we may reach the targets anyway. So I suppose it's a question of wait and see. I suppose in part to see if we do, but if we don't, I think it's got to be thinking about how we can encourage less people to bring their cars into the city for work, commuting, etc., and provide alternatives.
Yeah, absolutely, and that is absolutely part of the wider transport strategy that underpins, and all the daughter strategies that underpin and inform the air quality strategy. I think you're right, and I think that that's what the new air quality strategy tries to foster, is this mission to go a bit further. We can work to our targets, or we can have an ambition to have cleaner air in the city, and that will necessarily be a multiple pronged approach that requires transport input. It requires us all, it requires planning thought. All of the members on the Air Quality Board for this group have, each organisation has its own air quality strategy and commitment to that, and we're working as a city together to think about how we move around the city, but also the choices that we make on a day-to-day basis will have a positive impact. So I agree with you. I think it's a really important, it's not a simple issue.
Thank you. Councillor Winnington.
Thanks. Thanks, and thanks for the report. It's always worth making the point that for this report and this issue, it's not just about clean air as an abstract. Obviously, we know that it makes a difference to people's lives. So this is about people. And of course, we know people die of air pollution. And that has been confirmed. So this is a really important thing for us to concentrate on and look at. And as Councillor Heaney said, some of the solutions that we've been given by government in the city are perhaps not as exactly what we would have liked in an ideal world, not least about if you have a CAS, you have an area that doesn't have a CAS which you can go round, which for a lot of them. So for a lot of the vehicles that are relevant, but I think the way we have been moving forwards on this, and I think that point actually about everyone involved has got their own strategies on what to achieve. So that's working well. I think the key point here is, as Dominique has just mentioned, is that going beyond the targets that we've been given is really important, because the targets in the UK are less than the targets in other places, and indeed they are less than the sort of standards that is set internationally. So so we could say, oh well, we're meeting our targets for the UK, but actually that isn't clean air. That's just less. That's just slightly better, less polluted air than it is in other places. So I think us having an ambitious target on that is really important, because it is about people who are in the city, just walking around, doing activity, and obviously I'm going to say, as someone who cycles everywhere in the city, about if you're using the roads or you're walking past it as a pedestrian. So because you are exposed to it, but also if you're in your car. Because if you're in your car, especially things like this, you've got the maybe you haven't got air conditioning or whatever, you've got your window open. It's all a case of you're bringing in a lot of particulates, and you're breathing that in as you are driving around. So it's something that is important for all of us for so many different reasons, for activity, for general well-being, but also about the big thing about how we can do modal shift to get people to not to use polluting vehicles if at all possible, but also recognising that where we do have polluting vehicles, etc., that having congestion in the city is also a problem. So even if we had 80% of our vehicles were electric, but we had 10% more vehicles on our roads, which will happen if things don't change, you will still have, therefore, polluting vehicles will still be around, they'll be slower, they'll be presenting more pollution, and of course you've also got the additional things of things like microplastics and everything from tyres and whatever. So it's part of a really big bit of work, but I'm really pleased that things are moving in the right direction. But there's a lot more work to do in terms of where we want to be in terms of changing behaviours, and where we want to be in terms of making this city have as clean air as possible, and people buy into that as well.
Thank you. Thank you, everyone. Thank you, Dominique. And obviously we get regular updates about air quality, don't we, through this board. Thank you. Over to John now for Better Care Fund returns.
Thank you. So you're here to discuss the Better Care Fund returns, which are required to be agreed with the Health and Wellbeing Board. I think in the ideal world, we'd like to bring the returns here for full approval before submission, but because the timescales don't quite work, what we do is we have it agreed with Portsmouth City Council, NHS Hampshire and Isle of Wight Integrated Care Board, and then our Health and Wellbeing Board chairs approve, and we bring it to the meeting to ratify. So we've got two elements here. We've got the 24-25 end of year template, and we've got our 25-26 plans. So the attachments are in there. I do apologise. They are not friendly to read, and they are not friendly to use either. But if we start off with the 24-25 end of year report, I'll just give some highlights. So we've got 4 national metrics. We have avoidable admissions for ambulatory care sensitive conditions. We have emergency admissions for falls over 65. Long-term admissions to nursing and residential care, and we have discharged to usual place of residence. So we've achieved 3 of those targets in 24-25. It was the discharge to usual place of residence which we did not achieve. I think we did know it was an ambitious target of 95%, so we got 92.4%, which is a slight improvement from 23-24. We have to include some highlights as well, the end of year feedback. We've had some really big successes in 24-25, I think, particularly with regards to integrated neighbourhood working. We've been able to use the Better Care Fund to increase capacity in primary care. We've aligned our NHS community services around primary care network footprints. We've got allocated social workers, so we've got integrated MDTs that are set up, and it's really been supported through the Better Care Fund. Another achievement that we have noted is about the reconfiguration of our rehabilitation and reablement offer. So we used to have the Portsmouth Rehab and Reablement team and the Community Independent Service. What we did last year is we brought those services together and operating as the Community Rehab Service, and that seems to be working really well. We have to give 2 challenges. One of the challenges is relating to neighbourhood, because there's been limited national guidance. So actually what constitutes a neighbourhood is very subjective. Some people will feel it aligned to primary care networks, others will feel it's geographical boundaries, others will feel it's certain characteristics. So that has been a challenge, and we've just agreed in Portsmouth to operate with a mixed model. And we're hoping to bring that together. And another challenge has been the restructures of local NHS organisations, I think has to be noted. So that's the Integrated Care Board, our community partners and acute services as well. So that's just a high-level overview of our 24-25 end-of-year summary. Is there any questions?
No, but I will just comment on the PCN and the geographical thing. The difficulty is our PCNs often operate across the whole city, across the whole footprint. So because we're quite a small tight city. We've got 5 PCNs and the catch can be just all overlapping. So we have agreed to be more flexible, and we do have really good working across the PCNs anyway, and we also have the vehicle of our alliance as the whole city as PPCA, so we can be more flexible with how we offer the things, and I think that will stand us in good stead moving forward, because we'll try and go where the need is, not necessarily be confined to just one patch. So hopefully as we identify the needs, we can wrap our teams around the correct needs. I think that's what we're trying to aim, including voluntary sector and actually getting the communities themselves to come up and decide what they want and what they need. So hopefully it'll be good work to continue.
Okay, so the second one is our 25-26 plan. So we had a Health and Wellbeing Board development session at the end of February. So we discussed the proposed priorities and some of the key actions that we were looking to take. I think just linking to Dr. Colley's previous comment, so linking the neighbourhood model together. So there are 2 objectives within the Better Care Fund, reforming the support from shift sickness to prevention, and then supporting people living independently and the shift from hospital to home. So the sickness to prevention, alongside the publication of the BCF policy framework, there was also National Neighbourhood Health Guidelines, which is a document that we've been really hoping to sort of give some clarity. Fortunately, everything they've been working on was going in the right direction. So we've got 2 priorities from the neighbourhood health model, which is strengthening primary and community-based care to enable more people to be supported closer to home, and then connecting people access health and care to wider public services and third sector support. So this is very closely with our voluntary sector, social prescribers and our independence and wellbeing team as well within the Better Care Fund. And then from a rehab and reablement perspective, it's continuing the work that we were doing last year and really strengthening that reablement offer that we've got to our local residents. And then we are also looking at right-sizing our intermediate care resource to increase our home first capacity. So that was our 2 priorities that we priorities against the 2 objectives that we agreed at the development session. It's only a 1-year plan, the Better Care Fund. I think it says the government have decided on what the future is of the Better Care Fund. So we've been quite limited to the changes that we can make in this plan. I think the one big change that we have included is diverting resource that's previously been supporting escalation beds at Summerlee units. So there have been 10 beds, and it was following the bed reconfiguration in 2022. So it was always intended to be a short-term solution, just provide a bit of capacity. And now we're actually at a stage where we feel we can reduce those beds and divert that resource into community, so supporting more people to be discharged home rather than in a bedded setting, which is absolutely the right way to go to. And as I say, it's been a long-standing intention in Portsmouth. So that is really the sort of big change within the plan. And I guess just to update on the KPIs, there's been changes in the metrics. So we've got avoidable admissions for all over 65. We've still got a long-term admissions to nursing and residential care. And then we've also got a new one, which is about individuals discharged on their discharge-ready date, which is going to be quite challenging. Just to update, so we have submitted these plans. They have been provisionally approved by the regional team, but it's the KPIs which across Hampshire and Isle of Wight, all places are being asked to review those to make them more ambitious and aligned to our discharge advisory group, because we're intensive support. So it's not Portsmouth on their own, but it's all those areas in intensive support. So that is just a high-level overview. Are there any questions?
Helen.
It's not a question, John, don't worry. I just wanted to support you. It's really important to put the plan in the context of Health and Care Portsmouth and the plans that we have. We've just refreshed our delivery plans. So this is really very much, and John has been leading on this work, very much of a multi-organisational team as part of Health and Care Portsmouth, which we've all been part of. I know that it's fair to say that the Better Care Fund has always been, because it's more than money, but it is money. Therefore, it always becomes the contentious bit, doesn't it, between all of our partnership working. But I wanted to just say how positive still we are managing in Portsmouth to work in Health and Care Portsmouth with all of the partners, many of them around the table here. You know, we've got Lorna, we've got Ron, I can't see everywhere going round, obviously John and Fran from the ICB, but we, you know, Children's Public Health Adults, we've all worked also with our colleagues actually in housing, because a lot of the delivery plan we talked about today. So it's not been easy for any of us. There's so much change currently in the NHS, and I believe this week we will see the 10-year plan. HSJ have done a leak, as they seem to do all the time, before anything comes out. But it's really important because, again, we also in local government will be seeing, much change, that we've maintained those relationships and partnerships under, I think, when it gets very, very difficult. I just want to say that to support John, because he and his team have worked incredibly hard with everybody, of all of the partners. So even though it can be contentious, we always manage to get through it and work together really well.
Thank you. Any other comments or questions?
Yeah, I think just reiterating that, I think the bit of the forward plan that sort of brings that in is where it talks about the home first approach, and I think that really shows that working, and it references back in that part. Is it that bit? I'm just trying to find it. I was just looking at it. But it talks about, within the report anyway, it's about the plan forward, about the historical links that we've had when we had the old CCG. And I think that absolutely that health and care Portsmouth approach is massively important for us to retain. And I'd like to thank all the partners involved on, though sometimes it's been a bit bumpy, about making that work, and that we continue to be able to work together in making sure that we're providing what our residents need when they need it in the right way. And I think we use our Better Care Fund better in this city than a lot of places do in the country, because we do work together, and we're talking about independent wellbeing team. And that's a really important part that we can do, that is based in the council, but that has such a holistic impact on people in the city. So by being able to invest in that and have this plan signed off by all the partners, that's just an example of, in other places, if you haven't got the trust, and I always talk about trust, because trust is really important when you're doing about the partnerships. And again, in the last couple of years, come out of the CCG, coming into the Integrated Care Board, sometimes that trust has been a bit hard to maintain. But I think where we are now, I think we're in a significantly better place. I think we're back in a good place. Not exactly the same structures, but I think in terms of relationships, that's really important. And again, involvement in things like the Health and Wellbeing Boards, involvement in, as we were talking before about Combating Drugs Partnership, the other boards and partnerships we have where people engage. It's not like you turn up to a room and there's hardly anyone there. People are engaging together, and that's the way that we don't just work together in front of things, but it's behind the scenes, as Helen said, with John and his team, and making sure that we get this and we hammer out what we can do. And I do hope in the future, as again been mentioned, it's on an annual plan because that's all we're allowed to do, but I really hope under the I think the 10-year plan is imminent, so we'll hopefully as a result of that being published, that we might get in future some more longer term, maybe a 3 or 4 year plan for things like the Better Care Fund. Or if the Better Care Fund's not going to exist and it's going to be something else, then whatever replaces it, whatever is sort of across local authorities and the NHS, that we can have long-term planning rather than having to do this every year and we don't know exactly what we're going to get, and it's disruptive. But we know annual funding is disruptive. So yeah, I'd really like to commend this. Obviously, as has been mentioned, myself and Linda, we signed this off on behalf of the board, and I think we were really pleased with where we got to in actually good time. Even though we always have a very tight turnaround, it was even for that, it was really good time this year, and we got it in with rather than being like literally a couple of days' notice, which is never the fault of the team putting it together, but it's often the fault of when we actually know what our funding's going to be. But yeah, it's a really good bit of work, and it shouldn't be underestimated how much work goes into this and what a difference it makes to people in the city.
Thank you. So we're asked to ratify the submitted Better Care Fund end of year return for 24-25. Are we happy to do that? Lovely. And ratify the submitted 25-26 Better Care Fund plan, including all its narratives, planning templates, demand and capacity template. Lovely. Thank you very much, John. And last but not least, we've got Fran with the Integrated Care Partnership Joint Committee update. Thank you, Fran.
Thank you. It's just, I'll give a brief reminder and then cover a few of the elements in the report. So Integrated Care Partnership is a joint statutory committee between our local health and wellbeing boards across Hampshire, Portsmouth, Southampton and Isle of Wight, and our NHS Hampshire and Isle of Wight Integrated Care Board. But in reality, our Integrated Care Partnership locally really quite accurately reflects all the different partners around the room. So we've got BCSE, police, NHS providers, fire, OPCC. I always miss someone out, Healthwatch. But we're a much more diverse partnership in reality. And because of our statutory link with health and wellbeing boards, we like to make sure we're cross-reporting. So as a reminder, we've got 5 priorities as an integrated care partnership: children and young people, mental wellbeing, prevention, good health and proactive care, workforce and digital. And the report today really focuses on our workforce priority, which is, I think it's fair to say, been one of the priorities which has been the hardest to kind of get off the ground and work out what does it make sense for us to do at scale, and that adds value to what's happening at pace. So somewhat luckily, Get Britain Working came out in, the white paper came out in December, and the Integrated Care Partnership have been working with both the Get Solent working plans and the Get Hampshire working plans to think about how do we engage health and care partners into those plans. So not developing different plans, but making sure the health voice is in there. So in May, we held a roundtable as an integrated care partnership with our NHS providers, our integrated care partnership, and the teams from Portsmouth City Council and Hampshire County Council, who are pulling those plans together, and really discuss what could we do to really encourage engagement with the health sector and the health and wellbeing space, and really recognise that link between work and health, and not just work, actually meaningful employment and health. So we've identified some good practice across the health sector, and we've been working closely with Jane and the team in Portsmouth around really building that in. And next Monday, we have a wider engagement session. There is still space if people want to join us at our ICP Assembly to delve into the health part of the Get Britain Working plans. The other side of our workforce ambition as an integrated care partnership is also around keeping people in work and really looking after our collective workforce as an integrated care partnership. So we're going to be thinking a bit more about what we do, flagging that we've already done some good work as an integrated care partnership around some mental wellbeing toolkits for the workplace, the social connectedness toolkit that was developed that looks at how do you support connection in the workplace, and the trauma-informed work as well around having a trauma-informed workplace. So that was really what we wanted to update on the report. We have also included something on volunteering for health, and just an update on some of that work on volunteering for health. This week we've had agreement from the NHS charities together that we can progress into the next stage. So it's been quite a long process. We put the application, I think it feels like years ago, and I think it was years ago, across our NHS providers, the ICB, and HIVCA, that's our BCSE Alliance for Hampshire and Isle of Wight. We were successful, but there was a very long sort of planning process that we've had to go through to submit plans, and they've accepted our plan and will be into delivery phase. So Portsmouth Hospitals are running a local project, and actually Hampshire and Isle of Wight Healthcare Trust are also running a project. So really flagging that we'll be engaging with you a lot, much more, and be reaching out to the Health and Wellbeing Board to ensure that it goes broader than just volunteering in the NHS, but is really about volunteering for the health and wellbeing of our communities. Thanks.
Thank you. Any comments or questions? Yeah, go on.
As now as co-chair of the Integrated Care Partnership. So so I took over last month as the co-chair. So and as is mentioned at the end, it doesn't actually say about so 4.1. So it's always a Health and Wellbeing Board chair and a director of public health. So Simon from Hampshire County Council, director of public health. And lately of the Isle of Wight, but it's just Hampshire now. So he's staying on. We actually had a gap, and then we agreed between the Health and Wellbeing Board chairs of the different upper tier authorities that we would take it in turns. So we would do a year each. Last year we didn't have Hampshire, which it should have been, because they had a changeover during the year of their cabinet member, and it all got a bit messy. So so Simon did it on his own last year, but I'm in this year, and then next year it should be the Isle of Wight. So that would be how we'll work. But what I've really put forward this year as well, and so when we had the round table that Fran mentioned, is making sure that we strengthen those relationships, and this is also what we discussed with the other Health and Wellbeing Board chairs, strengthen the relationships with our Health and Wellbeing Boards, and really look at using all the assets we've got in the priorities. So it's not just about statutory, it's not even just about VCSE, it's also about thinking about workforce in particular, looking at our private care providers and things like that, because that's massively important to us in terms of making sure that we can provide care and support for people in the communities. On the report there, we've got all the things that we're working on. I'm really pleased that we have got this volunteering thing up and running now. Is a case of, it's an interesting thing. I'm just going to muse here for a moment. Interesting thing. I had a discussion with someone about this, and it's a case of, even though it's not NHS funded, it seemed like it's a charity. It's a national charity of NHS charities, and but they seem to have the same thing as the NHS in insisting you come up with a plan before they give you any money. But they don't give you any money to create your plan. So it's really, so it's like the way national NHS works is the way the national charities of NHS charities work as well. So it's a highly interesting way of doing so. But I'm really pleased, because that's the first I've heard as well, Fran, that we're moving forward with that. And it's very much about, so people can volunteer for health and care, and they don't have to volunteer every place. So at the moment, if you volunteer at QA, you have to volunteer again if you want to go to St Mary's. And if say you wanted to, and when we were still Southern Health and Solent, if you then wanted to go to the War Memorial Hospital in Gosport, you'd have to volunteer again. And so it's about having that, that flexibility of going across and really engaging with the communities. But as Fran said, still spaces for Monday. It's in Hedge End. I can't remember what time does it start, Fran?
1 o'clock.
1 o'clock. So please do get involved, as many people as we can get from our partnership. Our assembly is one of the things we used as an inspiration for our assembly and engaging with from our joint committee for the Integrated Care Partnership is this board. When I talk to the other areas, they are astounded by how many different organisations we have on this board and the breadth of it, and it's been a real inspiration in terms of how you can engage the whole of the health and social care sector and beyond, because we all have an interest in what's going on. And I think the Integrated Care Board finds it incredibly helpful having the amount of engagement we do through the Integrated Care Partnership. And the Assembly itself is almost unheard of around the country. You get virtually none of this, where we literally go out to our local organisations and say, come to us as the health and social care sector within in the integrated care system, come to us and talk to us and engage with us about things that are important to you, that have come through the priorities that have already been co-produced. So it's a real opportunity. So if you can't make this one, there'll be each one of our assemblies we do is always got one of the strategic priorities. So if workforce doesn't float your boat, but one of the others does, there will be, even if we've had an assembly about it already, we will have another, and there'll be a slightly different bit on there, and that it just really gives you an opportunity to get involved.
Thank you very much. And that draws the main items to a close. I just have to let you know that we have selected the dates for the meeting for 2026. We've been quite organised, and they're there on the piece of paper for you. So pop that in your diary. Our next meeting will be Wednesday the 24th of September. So have a good summer, everyone. Thank you.